Dr. Sarah Young, who did her PhD work at University College of London in biochemistry. Seems to be a theme here. She is currently an assistant professor of pediatrics at Duke University. There's another theme. And she is also the co-director of the Biochemical Genetics Laboratory at Duke University, and she's going to tell us about cerebral creatine deficiency syndromes, diagnosis by analysis of creatine and guanidino acetate in plasma and urine.
Thank you, Dan, and thank you for the organizers to give me this opportunity to talk to you today about a group of disorders that is dear to my heart. Can you hear me? Okay. Thank you. So my only conflict of interest is that I work for a diagnostic lab that offers testing for this group of disorders. And contrary to what you see in the program, I'm only going to show you one slide on mass spec, so don't worry. I'm going to start off with a bit of background on the creatine pathway. It's a very easy pathway to learn, so if you need to learn a biochemical pathway, this is the one. 2 steps. And you see that the first step is catalyzed by an enzyme, arginine glycine amidinotransferase, which does exactly what the name describes. It transfers an amidino group from arginine to glycine, producing guanidino acetate and ornithine. The next step is a methylation step. Guanidino acetate methyl transferase catalyzes that using S-adenosylmethionine as the methyl donor. In humans, this mainly occurs in the liver. Other tissues do have activities of these enzymes, but to a lot lesser extent. And we can also, beg your pardon, we also obtain creatine from the diet. From the site of production to where it's needed, creatine is transported in the blood. It's taken up by cells by a transporter that is coded on the X chromosome against a huge concentration gradient. So this is a facilitated transport. The tissue that contains most of the creatine, not glycogen, I'm not talking about glycogen today, sorry. Okay, I need more coffee. The creatine, skeletal muscle contains more than 90% of the body creatine, and this is because it's a very energy demanding tissue. Other tissues that are where creatine also plays an important role: heart, kidney, brain, and intestine. So creatine inside the cell serves an important role in maintaining energy homeostasis. It transfers high energy phosphate groups from the site of production in the mitochondria to where it's needed in the cytosol. It's phosphorylated by creatine kinases. There are different isoforms, one in the mitochondria and one in the cytosol. And the phosphocreatine serves as a buffer for these high energy phosphate groups. There is a spontaneous conversion within the cell, and this mostly occurs in muscle, so pay attention to this fact. Phosphocreatine and creatine spontaneously cyclize without the need of an enzyme. This is a chemical reaction, formation that occurs, forming creatinine, which can diffuse out of cells and excreted in the urine. And through this process, we lose about 2% of our body pool of creatine a day. That needs to be replaced. So over the last 20 years, deficiencies of both the enzymes and the transporter have been described in patients. Not surprisingly, the most common is the X-linked creatine transporter, and with over 100 patients described. They're all characterized by a deficiency of creatine in the brain, and this can be determined by proton MRS, where there is an increased signal for creatine. They all share similar clinical features, especially global delays and speech delay. There are behavioral abnormalities and seizures occur. Between the different disorders, there is variability in the phenotype. For instance, in guanidino acetate methyl transferase deficiency, seizures are observed in a majority of patients, and in about 1/3 they are refractory. And this is because not only do you have creatine deficiency, but you also have an accumulation of guanidino acetate, which is neurotoxic. So in addition to these shared phenotype typical features, there is also some movement disorders associated with guanidinoacetate methyltransferase deficiency and the transporter. There is myopathy, and this is a feature for AGAT, which is one of the most rare of the three. There is dysmorphism associated with the creatine transporter deficiency in some patients, but not all. And there is overlap, of course, with mitochondrial disorders, which the group of disorders does not overlap with mitochondrial disorders in metabolic chemistry. So here we have gastrointestinal dysmobility is a real issue for the creatine transporter patients. And we see organic acid abnormalities in the urine. Some patients have been misdiagnosed as having a mitochondrial disorder because when they had muscle complexes measured, these were deficient. And finally, I just want to point out that half of the females who are carriers for this disorder have a problem, may range from a mild learning difficulty to a more severe phenotype, including seizures. There is treatment for the first two disorders, the enzyme synthesis disorders. Restoring brain creatine is achieved by oral creatine supplements, and reduction of the guanidinoacetate is done with three ways: restricting arginine in the diet, removal of glycine with sodium benzoate, and reducing the activity of AGAT with oral ornithine. This does have a positive impact on the prognosis of these patients. However, if they have pre-existing cognitive deficits or speech delay, these will not be reversed. Patients who've been treated from birth have had normal outcomes, and that's very important. Unfortunately for the transporter, treatment is limited. People have tried giving the precursors, arginine and glycine, and this has been beneficial in a subset of patients. Creatine monohydrate may also help the muscle disease. There are lipophilic analogs of creatine, such as cyclocreatine, that can bypass the transporter and diffuse across the membranes. Preclinical studies of cyclocreatine have shown the most promise, and clinical trials are planned. So just talking about the diagnosis, from a biochemical point of view, we look at the metabolite levels in blood and urine. In AGAT deficiency, both guanidinoacetate and creatine are low. In GAMT deficiency, you have an accumulation of guanidinoacetate and creatine is low. In both of these disorders, creatinine, the cyclic form of creatine, is also low. We recommend in the lab that you test both urine and plasma. Why? Well, because you may miss a diagnosis of AGAT deficiency if you only test one. Specifically, in AGAT deficiency, there may be low but not clearly deficient levels of these metabolites in urine. For the transporter, the pattern is different. It's related to the fact that you have a decreased pool of creatine in the muscle, and this reduces the amount of creatinine that's produced every day. So your creatinine production and excretion in the urine is low. Also, the kidneys cannot transport creatine that spills out into the urine back into the blood. So consequently, you have an increased ratio of creatine to creatinine in the urine affected males, but this is not true for females. Females may have normal levels. Also, plasma is not useful in this disorder. Guanidinoacetate is normal. And finally, there are non-specific causes for elevations of creatine. So you need to show persistent elevation of this ratio in patient samples by testing more than one sample. So this is how we do it in the lab. It's an improvement of the original method that we published. It uses UPLC, tandem mass spectrometry, and hydrophilic interaction chromatography. It's what we call a dilute and shoot method. We take the urine, we mix it with these standards, and we inject it on the column. Plasma requires a protein cleanup step, but it's very simple. And this non-derivatized method allows the simultaneous measurements of the three metabolites, creatine, creatinine, and guanidinoacetate. And with the improved sensitivity of instruments these days, not only can we measure it in urine and plasma, but we can also measure it in CSF. And we are working up a urine spot method. So for the last 10 years, we've been offering this test, and it's not been a very highly ordered test, not compared with other metabolic tests. We've done about 100 patients a year, and from that group, we have diagnosed 3 patients. Additionally, 2 more patients probably had a disorder, but because they were not seen at Duke and they were either lost to follow-up or we didn't receive any more information on the patient, we weren't able to confirm. So this gives a combined incidence of about 1 in 250 to 1 in 400. So now I just want to share with you some of the case studies of the patients that we've diagnosed at Duke. But I did tell a little white lie in the previous slide, because even though that the incidence was in the patients here, these 3 patients, none of them actually had testing initially or had incomplete testing for the creatine transporter deficiency as their first metabolic screen. It was only when we suspected a problem or recommended the testing was the testing done. Oops. So the first case I actually presented 4 years ago here in this meeting. He was diagnosed at the age of 6 months with cerebral palsy because he had gross motor delay, hypotonia, and abnormal movements. The parents sought a second opinion, and the pediatric physician that saw him did an MRI that suggested a possible metabolic disease because of changes in the globus pallidi. Well, then she sent the usual metabolic screen. Of course, metabolic screening to most physicians means acyl-carnitines, amino acids, organic acids, not creatine deficiency screen. And so the low creatinine level in the urine resulted in a pseudo-elevation of the organic acids. And when I looked at this profile, I said, something's not right, please repeat it, you've made a mistake. Well, the poor lady who ran it, it was her very first sample after being trained on this assay, so we did blame her initially. But it came back as being normal, the same. And then so we said, aha, we called the doctor and said, do you want to order these other tests on the samples you already have in this lab? She said yes, we tested it, we confirmed JMT deficiency. So here the molecular confirmation was done over in Haya Solomon's lab in Amsterdam. At that time it wasn't available in the US, and proton MRS showed a decreased creatine. The patient was treated from the age of 13 months, and upon treatment, we have successfully reduced the guanidino acetate level. Remember, this is the neurotoxic compound that accumulates in this disorder, and this is one of the treatment goals. We've not been able to normalize it, no matter how hard we try, but it is slightly more elevated than you see in heterozygotes. The creatine is being maintained above the control range, which is shown in the gray box here. And this is to really promote this uptake of creatine by the tissues and to replace it. And plasma creatinine has been restored, and this is a reflection of the normalization of the intracellular creatine pool. So after the 4 years since I last showed an update, he has almost normal development, completed first grade. He's a lovely little boy, and he has speech delay that has resolved. He's had a lot of speech therapy, and he doesn't need it right now. Physically, he can keep up with his peers, and he's very active, and he's very social. So that's a good outcome for this patient, and it's likely that we just caught him in the nick of time, because patients with this disorder who are treated from a later age do not show improvements. This is the second case, and it's a creatine transporter patient with a significant family history of mild learning difficulties in the mother. He had the classic presentation for a creatine transporter, and this is what his testing looked like, of various mix of metabolic and genetic testing. Guanidino acetate and creatine, giving credit to the physician, they did send this testing, but they weren't aware that plasma only would not detect the transporter. So when, and additionally, we saw abnormalities in the urine organic acid that suggested mitochondrial dysfunction. Anyway, we made the recommendation, please send urine, which they did a year later, and then this showed we were able to confirm the transporter. And he was started on treatment of arginine and glycine. However, he's still severely impacted by this disorder. He has low IQ, some autistic features. So a third of patients with the creatine transporter do develop some speech, and he can speak in short sentences. 2/3 don't develop speech at all. He understands more than he can say, and his behavior, although when Jenny Goldstein, who interacts with these patients, sees them in clinics, wrote this, I'm thinking, what's abnormal about that? But apparently she reassures me this is a little bit more than children of his age usually do. His behavior is a little bit more abnormal. He's not toilet trained, but he does enjoy family life with on the farm. So the third case, this is the final case, and this is a complex family history, as you can see. This is a proband, and he had, again, phenotype that's very typical for a transporter. He had a younger brother who had also overlapping features of speech delay, constipation, and some other issues. When it was confirmed in this patient, interestingly, his brother was not affected with the transporter. After the diagnosis, sorry, I'm nearly finished. After the diagnosis, the family had 2 more boys, and unfortunately they were both affected, which was very sad for the family. So there was a significant family history. And of course, with such a difficult family history, he had a whole lot of testing done. Creatine was not part of it, but they showed many different, over several years he had all this testing done, and the organic acids showed, again, some abnormalities suggesting mitochondrial dysfunction. They then self-referred to the sequencing clinic at Duke and with Dr. Vandana Shashi, and they diagnosed the creatine transporter in this patient through exome sequencing. So we were able to do the confirmation in urine, and this is interesting that we are doing reverse biochemistry these days from whole exome sequencing, where we're asked to confirm diagnoses, where it used to be the other way around, and we're getting more and more of that. So with the two younger brothers who were born to this family after the diagnosis was known, we tested them very, very early. We were able to get a sample on the first one in his first day of life, and the creatine was elevated even then. And his brother, the same thing. At 5 days, his creatine was elevated. And so you see that the biochemical phenotype is there, at least in this family, from the start. Their clinical phenotype is severe, and there has been some improvements in the proband with this treatment regimen, but there is some, it's very hard to treat these patients currently with this. It's only partially effective. We don't know what the outcome will be for the 2 younger SIBs. The 15-month-old can babble but has no specific words. He's been followed for a possible cardiomyopathy. The 3-month-old has severe constipation, and there is concern that he may be having startings of seizures, although that was not confirmed on an EEG. So just to summarize, it's very easy to diagnose these disorders if you send a creatine and plasma to the lab. If you can only send one sample, send urine. You're going to capture all 3, or hopefully get suggestions of all 3. If you have a patient with a neurologic phenotype, send this test. Don't just rely on the standard metabolic screens. Early detection is very important for the first 2 disorders, GMT and AGAT. Why? Because they can be treated from pre-symptomatically. That has a really good outcome in these patients. They are both candidates for newborn screening, and actually I'm excited to tell you that Utah has started newborn screening for GMT as of June the 1st this year. And they are preparing to submit to the committee for approval for this, as on the recommended panel. The treatments are needed for the transporter, and all hopes are currently pinned on this cyclocreatine compound, for which there will be clinical trials, we hope. And I just hope that there will be more done for this particular disorder. So I just want to end by thanking the patients and their families, our collaborators who help us with the management of the disease and referral for the GMT patient with Dr. Haram. Andreas Schultz has been excellent in helping us with the treatment guidelines. And then of course, the people at Duke who work on these disorders in the lab and in the clinic. So thank you very much, and I'd be happy to take any questions.